Έχει ξεκινήσει τώρα. Ωραία. So, we'll study breast lesions today, and we'll start from macroscopic evaluation of the breast, a very crucial examination for early detection of breast cancer is self-examination, because each woman knows her breast better than any other clinician, so she has to touch the breast throughout both breasts, but it is better to do it on a specific time during the menstrual cycle, so it has to be a stable time that she does the self-examination of the breast. Anything you touch with increased consistency is not cancer, it's not so worrisome. For example, here you can see that there are some increased in breast stroma forming something like a tumor-like nodules. However, they are just increased amounts of stroma, very thick stroma of the breast, and they give an impression that it may be some sort of a small tumor. However, it isn't so, and this is quite common in women with diabetes mellitus. They can touch and see that all this increased consistency, which may be quite diffuse throughout the breast parenchymes, is nothing to worry about. Here we have another lesion in mammography, and you can see that it is not throughout the same. The contour, which you should always judge, as you'll see in the X-rays from the next semester, may give some suspicion if it is not regular enough. So there were some suspicion that this could be cancer, and that's why we have inked this specimen throughout. So this was a partial excision of the lesion, taking into account the mammographic findings. So, however, when we took sections from this area to see in histology, there were just accumulation of lipid-laden macrophage, because this is a tumor-like lesion that has nothing to do with the tumor. This is fat necrosis. And most commonly, there is some sort of prior trauma in the breast. Very rarely, it coincides with rare diseases of the fat tissue, such as Weber-Christian disease. It's most common something that has to do with a stressful stimulus affecting and destroying the breast, which consists normally of fat tissue. So if the fat cells break, macrophages go and phagocytose the lipids, and this may give a tumor-like lesion. And it is most important that among the stressful factors in which may this lesion be related to is radiation. Now that all breast surgery is more and more conservative, and total excision of the breast is not so common, then the surgeon has to be sure that the margins are tumor-free, even if the tumor is in situ carcinoma or infiltrative carcinoma. If it is in one side of the breast, there is no need to perform a total excision of the breast. You have just a lumpectomy. So if the lesion, you find cancer and it's quite close to the surgical margin, that means less than 1 centimeter, then you perform radiation so as to prevent local recurrence of the tumor. So if you get radiation, some fat cells may be destroyed and fat necrosis may develop. So, but this is, you understand that this is quite worrisome because there is also a history of cancer conservatively treated by a partial excision, by a lumpectomy. So if you see something growing in the area, you might be suspicious that cancer has recurred. No, it's not the case. In that case, we have just fat necrosis. Next. Here is the most common lesion, fibrocystic changes. You see that there is an increase in the fibrous stroma of the breast and some cystic dilation of ducts. It's very common, and it rarely causes symptoms to the patient. However, if a female patient is about 30, 35, and notes some changes in the consistency of the breast, the most common is that it's fibrocystic changes. So what does she do? She enters a mammogram screening program, and if there are any other lesions, for example, confluent microcalcifications that are suspicious for cancer, then she has the FNA, the fine needle aspiration biopsy, or a core biopsy, which takes a cylinder of tissue. And of course, if we see cancer, then she has to be surgically treated. Mainly in a conservative concept, not remove all the breast. Sometimes you have infiltrative cancer in one place, in one focus in the breast, and you perform a lumpectomy, but always you take care that the excision margins are safe. And other times you have multiple foci of even in situ carcinoma that necessitate a total excision. If there is multicentricity in the lesions, then you can perform total mastectomy. It is not so common, though, nowadays. Yes, look here. This is quite worrisome because this is a lesion which has some sort of radial configuration in its margin, and this is quite worrisome with cancer because breast cancer often, not always, often has an irregular contour, and it looks like a stellate contour. It looks like a radial. So, in this case, there was an excision. Perhaps there were some worrisome findings in the fine needle aspiration biopsy. However, it was just a radial sclerosing lesion. That means it consisted of some non-cancerous elements, which, however, especially when there was a degree of sclerosis in it, may give this irregular contour, which is worrisome. But it had nothing to do with cancer. And by the way, I'd like to stress the two lesions that are of the hyperplasia of breast parenchyma, which, by the way, consists of the dactylar lobular units. These are the units of the breast. So what are the two hyperplastic lesions that may occur in the breast? In one lesion, we see many small ducts, many more small ducts, which more common, they have a lobulocentrical, they mimic the normal lobule of the breast, so this favors benign. So if you see many small ducts proliferating in the breast, you are afraid that this might be a ductal carcinoma. So what do you see? You see that the margin of all this proliferation looks like a normal lobule, even though it is increased. The number of ductules are increased. However, if they retain a lobular architecture, this favors a benign lesion called adenosis. When adenosis is sclerotic and there is an increased amount of fibrous tissue, it might look worrisome radiologically, especially if there are microcalcifications in the adenosis. In such cases, you have to be sure, so you can have a small excision of the area. So you see that it is adenosis. By the way, the other criterion that you use to understand if a lesion is non-infiltrative, cancerous, is the myoepithelial cell markers. Why? Because normal breast ducts consist of two layers. Close to the basement membrane, we have the myoepithelial cells, which have contractile functions, so they express both epithelial markers, such as cytokeratin 14, and smooth muscle immunomarkers, such as actin, caldesmon, and other markers of smooth muscle differentiation. So, if a lesion retains at least some myoepithelial cells, it is not cancer. So, this is how you can rule out an infiltrative lesion in the breast. You see that there are at least some myoepithelial cells. So, in adenosis, myoepithelial cells are at least focally retained. So, you see that the ductals have myoepithelial cells. You see that the configuration in the margin of the lesion looks like a normal lobule. All these favor a benign lesion such as adenosis. The other type of hyperplastic lesion in the breast is when you see increased numbers of luminal cells, because the type of cells, as you already know, are the myoepithelial cells close to the basement membrane and the luminal cells close to the lumen of the duct. So you see increased layers of luminal cells, and this is called hyperplasia of the luminal cells, or alternative epitheliosis. It can be florid, however, it can be totally benign without any risk for cancer development. However, if there is atypia in the hyperplastic luminal cells, this increases the risk for cancer, so this patient must enter a more intense follow-up program. But I won't be too analytical because I want to stress these factors in the slides, but just as preliminary information. So, look here, these confluent microcalcifications, they are quite worrisome, and you see that when you perform a lumpectomy, if there are some suspicious findings radiologically or in FNA biopsy, and you want to make it orientated, because sometimes you get the specimen, the tumor specimen, and you perform an X-ray in the lab, in the pathology lab. Why? Because the surgeon wants to know whether he has excised the microcalcifications. Of course, there is some sort of stereotactic examination of where he cuts. That means he does not cut on its own. He has an radiologist nearby, and they cooperate to what they will excise. However, it is of crucial importance for the surgeon to know if he has indeed excised the microcalcification. So that's why when we always see microcalcification under the microscope, we report this in our pathology reports, and sometimes we even take X-rays of the specimen. Yes, please.
Professor, in our lecture that we had with breast lesions, so the professor said that when you have both myoepithelial and the inner epithelial layer, then it's benign. But you said that also if you have hyperplasia of these layers, it may be benign, yes. And if there is atypia, then it's...
That's right. Because, very good, very nice question. And please pay special attention to the breast, because it's the most common cancer in females, so you must be familiar with the lesions. So, we have this hyperplasia of luminal cells, and basal cells, myoepithelial cells are retained. If there is atypia, it can be one type of pre-invasive cancer, that means in situ carcinoma, ductal in situ carcinoma, which, however, needs excision, but this is a total different natural history than women having an infiltrating carcinoma when they are diagnosed, because if the basal cell, the myoepithelial cells are retained, we have a precursor lesion of invasive carcinoma known as in situ carcinoma, either ductal or lobular, as we'll see next, okay, in the slides. So this is not invasive cancer. It cannot metastasize. However, if it is widespread in many foci within the breast parenchyma, sometimes the surgery is radical, because all these areas have to be removed, surgically removed, because on this background, invasiveness is imminent. It may happen anytime. So you have to excise in situ carcinoma, all right? Next. Here are some specimens. You see that I have inked that specimens, and you see that the surgeon, cooperating with the radiologist, has sent me, along with the specimen, the lumpectomy, for example, this, so how shall we call this in English? This is some sort of marker that shows where the microcalcifications are, and it tells me that during the course of this marker, I have to take multiple sections and find the lesion with the microcalcifications. Of course, if it is a small specimen, you always examine all of it with histologic sections. However, since you have this orientation here, and you have some sort of sutures, you see the sutures here, the surgeon wants to know if this is cancer, either in situ or invasive. What's the distance from each margin? So he makes notes of the margins. One is close to the nipple. The other is deep, the deep margin. The other is, as you see, the quadrants of the breast. The quadrants, the upper quadrant, the lower quadrant. So each suture has a specific indication. So if you find cancer, you have to count the distance from the closest margin and name the margin. For example, the distance from the deep margin, which you cannot see because you do not have the breast, you just have a lump. So you look at the suture, that color is the deep margin. So the distance of the cancer from the deep margin is 3 millimeters. If it is less than 1 centimeters, then the surgeon thinks that the patient will benefit from radiation therapy, so as to prevent local recurrence of the lesion. So this is the use. Now, can you find it in English? Because I do not know what is this called. In Greek, it's odigosyrma. Odigosyrma. What is that? Driving wire. Yes, yes. That's right. So if there is a driving wire, I have to check through its course, where it goes, all the tissues, and possibly with deeper levels of sectioning. Not just one section, deeper levels, because you have to find the cause of microcalcification deposition. It can be cancer, it may not be cancer. It's up to you to find what's going on. Here is again, you see, the same. It marks an area which has to be thoroughly examined with sectioning. And here are some benign lesions. You see that the contour is quite regular, and you see that it is a duct with a proliferation within, which looks like this macroscopically. What is this? These are papillae. So, and this is a common cause of nipple discharge, either serous or bloody. If a woman about 40, 45 sees a nipple discharge of either serous or bloody consistency, the most common lesion is benign. And it is an intraductal papilloma, which As it grows, the papillae erode one with the other, and there is some bleeding from their fibrovascular stalks. So it's not worrisome. This is much more common, a benign lesion than a papillary carcinoma. And how can you tell the difference? You stain the markers for myoepithelial cells. Cytokeratin 14, SMA, P63, calponin, caldesmon, each lab has its own that knows they stain well. So if you see myoepithelial cells, this is not invasive cancer, okay? Here is again, you see the papillae? Now this is the duct which has been distended, and all these projections here, and you see they look a bit brownish because this is what a microscope shows as apocrine metaplasia, which is a benign procedure, here on the background of a papilloma, of an intraductal papilloma, a benign lesion. Again, you can see all this cystic configuration is consistent with papillomatosis if there are multiple papillomas in the breast. Here is another tumor, much more common. We'll see it under the microscope. It's not sure that it is a true tumor or some sort of nodular hyperplasia of the stroma of the breast. Anyway, we treat it as a tumor, a benign tumor, and this is the smooth contour of the tumor. This is a fibroadenoma. That means a tumor that consists of the fibrous element of the parenchyma of the breast. Benign, fibroadenoma. On the contrary, when the stromal component of a tumor is too cellular, then there is another term which sometimes may prove malignant. This is the phylloides tumor of the breast, which is found in older patients than fibroadenomas. Fibroadenomas, by the way, may reach gigantic dimensions during the puberty, and that might be worrisome. However, they are fibroadenomas. On the contrary, these phylloid tumors, when they have increased mitosis in their stromal component, perhaps necrosis as a sign of malignancy, and an increased size, this is worrisome, that may metastasize, and since it's the stromal element that it is the neoplastic element in phylloides tumor, the stromal element is the neoplastic one, not the epithelium that just is residual. How will it behave when a phylloides tumor shows malignancy and give metastasis? Where do you expect it to give metastasis, since it is not of epithelial origin, but it is of stromal origin? How will it behave? Which tumor will it resemble in its metastatic spread? Which tumor? Since it's from the stromal element, well, where do you expect to give metastasis? Yes, please. It derives from connective tissue. It is a malignant tumor of connective tissue. How do we call malignant tumors of connective tissue? So it will behave like a sarcoma. So as we know from the previous semester, where do sarcomas metastasize more frequently? Where do they metastasize? In contrast to carcinomas, which mainly give lymph node metastasis, sarcomas mainly give hematogenous metastasis. So she might develop metastasis in the lungs, for example. It's not necessary that epithelial malignant tumors, carcinomas, do not metastasize hematogenously. However, the first metastasis of a carcinoma is logically to lymph nodes. The first metastasis of a sarcoma is more frequent hematogenous. That means in distant organs. Okay, this is the uterus.
Because yesterday...
Uterus has two kinds of tumors. Some of epithelial origins, known as carcinomas, different types, estrogen-dependent, estrogen non-dependent, and some stromal tumors. The benign are leiomyomas, and the malignant are leiomyosarcomas. Leiomyosarcomas can have hematogenous spread. Carcinomas, endometrial carcinomas, more logically have lymph node metastasis and mainly nearby. Nearby. That's why you perform a total hysterectomy and you resect the neighboring tissues, because you look for lymph nodes there to see if they are tumor-free or not, if they are metastatic, and so stage the tumor accordingly. Okay? You are doing the female tract. Okay. Now, yes, please.
What is this, the mechanism behind this deep differentiation of the tumor? For example, there are many cases of melanoma that turns into sarcoma on the hand, and they sarcoma-like.
That's an exception. There is evidence of dead differentiation when the morphology of a tumor is no longer consistent with the cell from which it derives. For example,
Is a mechanism to adapt to our therapy, or it may be independent?
sometimes in sarcomas, yes. In sarcomas, it's some sort of response, or not exactly response, of alteration, because some chemotherapeutic drugs are mutagenic. Yes, but however, these are rarities. Okay, it's not the rule. You should always take care of that. So, now, here is a malignant phylloides tumor with perhaps some areas of necrosis and some diverse microscopic image. Here is ductal carcinoma in situ. You see these confluent microcalcifications, and sometimes if you have ductal carcinoma in situ and you squeeze the tumor, then you see the comedo-type necrosis as a necrotic material coming from the ductal carcinoma in situ. It looks like the acne that some adolescents have. When you press it, this necrotic material that comes from the lesions of the skin looks like what comes out if you squeeze this specimen. So this is the comedo necrosis. Next. Here is lobular carcinoma in situ, which, however, rarely forms a tumor lesion and you see a mass. More common, lobular neoplasia, either in situ or invasive, lobular invasive carcinoma, have no macroscopic specific image, and you have to take many sections to find the cells of lobular neoplasia, either in situ or invasive. However, in this case, you see that lobular carcinoma may form a discrete mass. It's not the rule. And by the way, you should take into account that among types of breast cancer, lobular cancer is much more common bilateral. So if you have a report that the cancer, either in situ or invasive, is lobular, always check the other breast. There might be cancer in the other breast as well, especially when you have lobular carcinoma. This is not lobular carcinoma, this is ductal carcinoma, not otherwise specified, the common type of breast carcinoma, and you see quite a heterogeneous cut surface, and from a clinical point of view, what is the sign that here is a carcinoma? Being a carcinoma, it infiltrates the surroundings, so you cannot detach it, you cannot feel that it is somehow smoothly shaped. Why? Because it invades and it's not movable. You cannot move the tumor because it invades the surrounding tissues. And what is the evidence here that you have cancer? Yeah. Yes, you see that the nipples and some part of the skin makes, how do you call that, goes deep. Why? Because the cancer takes it, and it's like forming, look here, you see the nipple here? It goes inside. Why? Because the cancer somehow distorts the architecture. And of course, it will be an irregular mass, and this is invasive cancer. And you see that more common, not always, but more common, it has a stellate contour, indicative of invasion. See how it invades fat tissue. You see how irregular the contour is in this carcinoma? And there are some specific types. What do you think? If this is an invasive carcinoma, which is quite rare, you see these projections here that are part of the tumor? Do you remember this? This is a papillary carcinoma, invasive carcinoma. So at least in some areas there are no myoepithelial cells because this is consistent with invasion. And for the specific types, either papillary invasive carcinoma or this one, I think it's, this is the myeloid, medullary. The medullary pattern, which is not actually a subtype of invasive carcinoma, but it is a pattern that the tumor, although malignant, is well circumscribed. You see how well circumscribed it is. This is not a subtype of carcinoma as the previous one, the papillary. It's just a pattern that some ductal invasive carcinomas can follow. And another type here, you see here again you have the medullary pattern, quite well circumscribed. And this is probably the pure mucinous type of cancer. And this is metaplastic, highly aggressive. And here there are some distortion of the nipple. And you can have some malignant cells here in the nipple within the epithelium, and this is called Paget's disease. What is Paget's disease? When malignant cells go from a cancerous, more common invasive, less common in situ, and they go through ducts and reach the skin, and they are intraepidermal cells. This is an intraepidermal adenocarcinoma. And when you note that, it does not have to do, you see it red, it has nothing to do with inflammation, because there are malignant cells, adenocarcinoma cells, within the epidermis, and always below there is either in situ carcinoma or more common invasive carcinoma. This is Paget's disease. And here are some aggressive types of cancer. And of course, you should always check the axillary lymph nodes when there is a tumor, because if you see lymphadenopathy, then this raises suspicion that the tumor is invasive and has already metastasized. And a very interesting topic from a surgical point of view is when do you perform axillary lymph node dissection in the patient? In what meaning? If the patient has already developed metastasis, why do you think you have to dissect the axillary lymph nodes? What's the concept of dissecting the axillary lymph nodes? Perhaps you can have a sentinel lymph node and stand it for frozen sections and tell you that it has metastasis. That means that the other axillary lymph nodes also have metastasis. So why do you think you think of making an axillary lymph node dissection? Why? What do you think? Yeah.
To find the route of dissemination of the cancer.
It's for staging purposes. It's not therapeutic.
Yes, it is.
It's for staging. For example, the survival of the patient won't be the same if he has less than, I'm not sure what the N parameter of TNM stage is. So when we perform lymphadenectomy, the purpose is for staging the cancer, because this is the most valuable prognostic indicator of the survival of the patient. It's not from a therapeutic point of view, because if you understand that the tumor has already developed lymph nodes, then you have the primary tumor, you check the immunoprofile, and you give the appropriate targeted or non-targeted therapy. Hormone therapy you always give in breast cancer patients. However, with the types of cancer that you have already discussed in the lectures, you define what's the specific chemotherapeutic drug that might treat the metastasis. So when you resect the lymph nodes, it's not a matter of therapy, it's a matter of staging, primarily, okay? So now let's see our slides. You can open your slides from the documents in your electronic portfolio. Now, here we are. Let's start with this slide, the fibrocystic changes. So, look, why have we inked the specimen? We have inked it because if we find cancer, either in situ or invasive, you have to count the distance from the surgical margin, the closest distance, and define the margin. However, this was not a case of cancer. Here we have some sort of, you see this nodule with compressed ducts due to an increased amount of stromal tissue, which, however, is not cellular. So this looks like a fibroadenoma within the concept of fibrocystic changes. Now, look here at the normal terminal unit of the breast, lobulodactylar unit. And you can see nearby some increase in the fibrous stroma, thus we say fibrocystic changes. Where are the cysts? Are there any cysts? Here there are some cysts, compatible with what the term implies. And here we have, I want you to see this and tell me, look at this terminal unit of the breast, normal. You can see the lobule and the myoepithelial cells. These are the myoepithelial cells, all right? And what's the difference in this? Have a look at this lesion and the nearby terminal units of the breast. What's the difference? And what is the resemblance apart from the difference? What do you think? Have a look at the contour of this lesion. Is it irregular or smooth somehow? It's somehow smooth. This favors a benign. This favors a benign lesion. Secondly, we see many, many ducts which, however, retain a lobular architecture resembling that of the normal unit of the breast. And if we look closer, look, all these ductules seem to retain, have a look here, two layers of cells, the luminal ones and the, have a look at these ones here, the myoepithelial cells, which of course can be proven by specific immunomarkers, such as P63, calponin, caldesmon, CK14. So, do you remember how do we call this hyperplastic lesion of the breast, in which we have a proliferation of ductules, which, however, retain a smooth lobular type margin, like normal lobules of the breast, and consist, the ductils, the hyperplastic ductils, consist of two types of cells, close to the normal breast. That means luminal cells and myoepithelial cells. How do we call this type of hyperplastic lesion? Yeah. Adenosis. This is adenosis. I cannot say that this is sclerosing adenosis because I do not see enough fibrous tissue within the proliferating ductules. This is adenosis. it does not increase the risk of cancer development significantly. Very, very small increase in the risk of cancer development in the future. So this is adenosis. What do we see next? Look here. How is this lesion here different from the previous lesion we saw? Have a look at this one, this focus of adenosis. Look here, and by contrast, have a look at this one here. What's the difference? What do you see here? Yes, please.
There's much more stroma.
Yes, there is much more stroma, and the whole configuration is somehow distorted because as the stroma goes in the lesion, it somehow gives it a radial appearance, which radiologically may be quite worrisome. So this is a radial sclerosing lesion, which may be suspicious radiologically. However, histologically, there is nothing suspicious for cancer because this is a adenosis. You see increased number of ductules proliferating, some of them microcystically dilated, like these. And have a look at the cells. They somehow show, look at these apical snouts. You see these snouts of the cells? This is a lesion of cylindrical cells. And if you look closely in the proliferating ductules, what cells are you able to identify? This one, this, myoepithelial. So you perform immunohistochemistry to be sure that myoepithelial cells are retained, and you say that this is benign. So this is a radial sclerosing lesion which consists of adenosis. Sclerotic adenosis, you can say. Yes, please.
You said before about the snouts. What are
The snouts, yes. These micro projections, which sometimes the luminal cells have. You see, these are the snouts. This here. Cytoplasmic, yeah, cytoplasmic snouts, yeah. So, is there anything else in this slide? No, I don't think so. Fat tissue, normal constituent of breast, and increased fibrous tissue consistent with fibrocystic changes. Let's see if there is another slide. No. So, a fibroadenoma. Have a look. A benign tumor, round in the margin, round margin, and you see that it is a benign entity, perhaps neoplastic, a benign neoplasm, let's say so, and as it grows, it expands. It does not infiltrate surrounding tissue, it just compresses surrounding tissue, forming thus a pseudocapsule. This is the pseudocapsule, you see? What is this? It's fibrous tissue of the adjacent parenchyma being compressed by the enlarging benign tumor, the fibroadenoma. There is a fibrous component, quite prominent, and it consists either of compressed ductules. See the myoepithelial cells, proving that it is a benign lesion. Here are myoepithelial cells, and some other ductules here, in which you can also identify myoepithelial cells, proving that this is benign. It's either the intracanalicular or pericanalicular pattern. They are of no clinical significance. This is a benign tumor, a fibroadenoma. And what's its differentiation? What is this tumor's differentiations? Since you see ductils practically identical to the normal ductils. That means that these ductils we see here forming a tumor are identical in morphology with all other ductils of the breast. So how much differentiated is this benign tumor? Yeah. What is this? There? High differentiation, but this is a term that we use in cancer. So you cannot say that this is a low-grade tumor because it is not malignant, it is benign. So you can just say that this is complete differentiation. Don't use the term high differentiation because this applies to grade 1 malignant tumors. That means low-grade tumors. If it is a benign tumor, what do you see? If it is totally benign in appearance, you say that its differentiation is complete. It's perfect differentiation. If you do not see the cells looking totally normal, and there is some degree of atypia, how do you term that? In a benign entity, non-invasive. However, the cells are not like here, identical to normal ductules. They are somehow atypical. What is the term for this lesion? That there is no invasion. This is not true carcinoma, not invasion. However, the cells have some atypical features. What's the term for this entity? Dysplasia, yes. Either when you have a benign tumor as this, it may be either fully differentiated, completely differentiated, as the case here, or it may have some degree of dysplasia, defining the pre-invasive status of some sort of malignancy. So this is the fibroadenoma, and since it is one of the two fibroepithelial types of breast tumor, the other one being fibroepithelial tumors of the breast. One is fibroadenoma, benign, always benign. The risk of malignant transformation is 1 per 1,000. It's very, very low. However, the other type of fibroepithelial tumor may have some malignant potential. You remember the name of the other type of fibroepithelial tumor that may behave in a malignant way like a sarcoma? Phylloides tumor, okay? That one is a fibroepithelial tumor that more attention is needed to the patient. So, and since it is composed by all this fibrous component, it will be hard as you touch it. It will be hard because it has fibrous tissue. However, being benign and just expanding, non-infiltrating the surrounding tissues, it will be movable. It will be easy if you touch it, that it will be a movable lesion. And this favors benign status of the lesion. So that was the fibroadenoma. And there is also one here, another fibroadenoma. Nothing special. The same intracanalicular and pericanalicular patterns, and the same. Here it is. Here is the tumor. Now, let's go to in situ ductal carcinoma. Look, you have all these lesions here, which are distended ducts, some of them with this necrotic material, which has some nuclear debris in it. Do you remember how we call this material, which is common in ductal carcinoma in situ, more commonly of high grade? This is comedo necrosis, all right? And it is compatible with high grade ductal carcinoma in situ. So, these ducts here are distended due to the proliferation of the luminal cells. However, you can see this deposition here. What is this here being deposited, which I said you should always tell the surgeon that he has excised this deposition. This is microcalcification. So this specific ductal carcinoma in situ was radiologically apparent due to its microcalcifications, which were removed, surgically removed, with the ductal carcinoma in situ itself. So we have to report that we see the microcalcifications, and furthermore, if we perform immunohistochemistry, we have to find some cells here close to the basement membranes which are retained, although somehow pressed by the atypical cells. And this tells us that this is not an invasive tumor. At least some of these cells here close to the basement membrane are myoepithelial cells. And this is compatible with in situ carcinoma. Now, what do we report? What do we report in a ductal carcinoma in situ? First of all, the grade, which is based on the pleomorphism of the nuclei. There are 3 grades: low, intermediate, and high. High grade is easily recognizable because the nuclei are highly pleomorphic. And often it has comedonecrosis. Comedonecrosis is not only observed in high-grade tumors, however, it is more frequently observed in high-grade tumors. But in order to define the grade of ductal carcinoma in situ, we look at the size of the tumor. Here, the high point is low-grade carcinoma in situ, ductal carcinoma in situ. Why? Because low-grade carcinoma in situ does not have pleomorphism. The cells look homogeneous in size and appearance, and this may be confused by the hyperplasia of luminal cells with no atypia, which is totally benign even if it is florid. So how can you tell? If you see cells within a duct that have no pleomorphism, this is worrisome, because it might be a ductal carcinoma in situ of low grade. So what do you have to do? You have to check the clonality of the population within the duct. And the more easy way to do so is to perform immunohistochemistry for estrogen receptors. If all the cells express estrogen receptors, this favors clonality. So, despite its low-grade appearance, the non-atypical appearance, it is ductal carcinoma in situ of low grade. The same applies to other markers, such as cytokeratin 14. Why? Because cytokeratin 14 stains the myoepithelial cells. Yes, it's normal because myoepithelial cells are retained both in normal ducts and in ductal carcinoma in situ. However, when cytokeratin 14 stains all cells within the duct, this is another evidence of clonality consistent with low-grade ductal carcinoma in situ. So, from a morphological point of view, if you see a duct being filled with cells, you have to think, is it hyperplasia of luminal cell, or is it low-grade ductal carcinoma in situ? If they are too homogeneous in appearance, this favors ductal carcinoma in situ of low grade, of course, or intermediate grade. So the challenging diagnosis here is low-grade ductal carcinoma in situ because it has non-so-atypical cells, not big nuclei, however, clonal in nature. Okay, This is the ductal carcinoma in situ. I think here that you see comedous necrosis. If not of high grade, it is at least of intermediate grade. So in this way, you would not be confused with hyperplasia within the duct. Let's see if it is well excised. Let's count the distance of the surgical margin. And why do we ink the specimen? You ink the specimen because you want to define, is it where you cut as a pathologist that you take the section, or is it the surface that the surgeon has cut? So that's why you have to ink the specimen. So if you see the ink, that's the surgical margin, and from that you count the closest distance, because if it is less than 1 centimeter, you have post-operatively to perform radiation, so as to prevent a local recurrence of the ductal carcinoma in situ. So let's see if there is anything else here. We saw the microcalcification. Here is another one, the comedonecrosis. And this is probably of intermediate grade as far as nuclear pleomorphism is concerned. And another crucial factor, of course, is the maximum diameter of the ductal carcinoma in situ. If it is more than 1 centimeter, it is a poor prognostic sign. So you have to count the nuclear grade, the distance from the surgical, the closest distance from the surgical margin, and the maximum diameter of the lesion itself. These are the 3 factors in the pathology report which tell you the prognosis of ductal carcinoma in situ of the breast. Next, we'll have the ductal invasive carcinoma, not otherwise specified. So, yes, please?
It's more therapeutic approach, right?
Yes, if I know from therapy, yes.
When is neoadjuvant therapy preferred?
Yes, neoadjuvant, yes. Never in situ, no. You give neoadjuvant therapy in invasive cancer. So if for some reason you want to shrink the tumor and make a more conservative surgery for some reason, what do? You take a biopsy. I find the invasive cells. I perform estrogen receptors, progesterone receptors, Ki-67 proliferating index, and HER2, and based on these prognostic markers, immunopositivity, you may give some therapy, neoadjuvant, and see how the tumor responds, and then consider to perform the excision. It is implemented in breast cancer. I feel not so common as in other cancers, but it is a concept in the therapy of this cancer. So here, as I say that these are invasive formation, invasive tumor formations, if I perform a stain identifying myoepithelial cells, what do you expect these stains to be? This is invasive carcinoma. So there will be a complete lack, a complete absence of myoepithelial cells. No P63 staining in the periphery of these islands of neoplastic cells, no Caldesmon staining, no CK cytokeratin 14 staining. So these are malignant cells, and being malignant, I have to grade the tumor, because now we have invasive cancer, so we have to define the grade of the tumor. Grading invasive breast carcinoma of no special type, which is the most common type of invasive breast carcinoma, you have to examine 3 factors. First, you have to see the architecture of the cancerous cells, if they are solid or they have lumen. If you count the percentage of luminal differentiation, If it is more than 75%, between 25 and 75, of less than 25. And this, you put the grade. If the solid architecture predominates, you put 3. If the luminal architecture, that you see glands, glandular differentiation, if glandular differentiation is evident in more than 75% of the tumor mass, you put A. So you have 3 grades, 1, 2, and 3. 1 parameter. Have a look here. Which part has luminal differentiation and which part has solid configuration of the invasive cells? You can see that in the right part, some lumen are retained. Show me the lumen in the right part of the tumor. Where is the glandular differentiation? You see? Here. So, in this part of the tumor, this part of the tumor, which retains lumina in the cancerous, invasive cancerous cells, here they are, is better differentiated than the other component of the tumor, which has solid structures. So you count the predominant pattern and how the percentage within the whole tumor area. And you put the grade. Any question? Yeah.
You said it's the luminal.
Where are the lumen? Yes. Let me see. Here they are.
Yeah.
Yes, here it is. The right part has the lumen. Here we have solid sheets.
So
Yes, solid structures.
What was the percentage to determine the
I think it's 75. If the solid pattern is more than 75, you put grade 3, the highest. If the solid compartment is less than 25, you put grade 1. But I'm not sure, check it up, because this is the Nottingham scale of grading breast carcinoma. Just check it because it's a matter of theory. Next, you have to appreciate nuclear pleomorphism. And you put 3 points again. 1, if there is minimal pleomorphism in the invasive cells. 2, if there is intermediate pleomorphism. 3, if the nuclei are highly pleomorphic. And the last parameter in grading is the mitosis. You count the mitosis in high power fields and grade the mitotic activity as low, intermediate, and high. Thus, you have a score of a total of 9. And so you have the grades now. If your score is up to 5, I think 5 or 6, it's grade 1, low grade invasive carcinoma. If it is 6 and 7, the score, it's grade 2, which is the majority of invasive carcinomas. And if it is 8 or 9, it's grade 3. But please check it from your textbooks, all right? What is that there? What is that?
Is it the plasma?
Let's have a look at that. Some cell is shrinked. This is carcinomatous cells that have shrinked probably due to apoptosis. But I'll check. What I told you about the Nottingham, please check in the textbook, all right? To be sure. Next. You see, yes, this cell. It has somehow a plasmacytoid appearance. However, you see how pycnotic the nucleus is. So this might be in a pro-apoptotic stage. Now, the staging of the tumor. Look, what happened here? You see the skin, epidermis, being ulcerated and hemorrhagic, destroyed. The epidermis is destroyed because of the cancer which is right underneath. So this pattern of invasion of the skin is compatible with the highest local spread of the tumor, which is pathologic stage T4. T4. In previous stages, you have to assess the maximum diameter of the tumor. Less than 2 centimeters, more than 2 centimeters, you'll check the staging system, pathologic staging system from your textbook. So, this is advanced, locally advanced carcinoma, ulcerating the epidermis. You see how the epidermis, look, this is the squamous epithelium of the nearby epidermis, which is here completely destroyed. Completely destroyed. And next, we have to look at these structures and tell me how do they differ and how do they resemble to the invasive ones. Look, the cells are the same as these, which is the invasive component. However, you see that at least in this structure, the contour of the structure is smooth. It's not angular as in the invasive component. You see here how irregular the tumor island's margin is. You see how irregular all these angles. You see, however, here it is quite regular, and it consists of cells similar to the invasive carcinomatous cells nearby. And you perform an immunohistochemistry stain, and you see some P63 positivity close to the basement membrane, or some cytokeratin 14 positivity, or some calponin positivity. So how would you term this lesion? It consists of carcinomatous cells, like the adjacent invasive component of this tumor. However, in these structures, some myoepithelial cells are retained. How do we call this lesion? How do we call it? It consists of carcinomatous cells, atypical cells, but it retains. How do we call it? Remember? Oh, no problem. Who knows it? Yes? What cancerous lesion? In situ. Ductal in situ carcinoma. Precancerous, yes. It's pre-invasive. All right? Yes, pre-invasive lesion, termed as ductal in situ carcinoma. Okay? So, if you have an invasive breast carcinoma which has an in situ component, you'd better tell the surgeon that there is an in situ component. You quantify it, if it is big, small, and you count the distance from the surgical margins of both the invasive component and separately of the in situ component. That's what you have to report. So that was the ductal invasive carcinoma of no special type. And now we'll see a special type. So, where is it? Look here. Look at this scirrhous stroma and look at these cells which are, look, how they are arranged one with another, and this has been termed an Indian file pattern. Can you please show me what an Indian file is? Check it please in your, where are the mobile phones? I think here we have a good, here, yes, we have a good, the open, check please in Google Indian file pattern. I want to see what the Indian file pattern is, because these cells here are arranged similar to Indian file. So what's the Indian file? Let me show you. What is that? Let me find it please. Indian file. Lobular carcinoma. Indian file. Yes. What is the Indian file? Yes. What? Ah, this is the Indian file. This one from the other. This is, yes. Ah, yes, this one. This is the Indian file. That's new. Yes, new. Okay. It's like one man with the other walking together, the soldiers.
Like
They're like this. You see? This configuration. And these are the lobular, invasive lobular carcinoma cells. So you'll check your slide to find the Indian file pattern. And there is a scirrhus. Look here. You see? It's quite typical. So since this specific tumor type is connected with loss of E-cadherin. This is poorly cohesive cells, which often, though not always, often, but not always, lose E-cadherin adhesion molecule. And this helps in the diagnosis of lobular neoplasia here in situ. Sorry, not in situ here, invasive here, but even lobular carcinoma, either in situ or invasive. What does the surgeon have to do if he gets a report of lobular carcinoma? Either in situ. What is lobular in situ carcinoma? You have a lobule and the unit, the structures are distended by these cells. However, myoepithelial cells are retained and there is no invasion. These are different cells than those of ductal carcinoma. Different cells, morphologically different, more small cells, more homogeneously appearing, with the exception of pleomorphic lobular carcinoma. But the classic lobular carcinoma that we study now has an homogeneous appearance in the invasive cells, because here we have an invasive carcinoma. And what else? Have a look here. The cells now come and invade fat tissue. Look, you see fat tissue invasion by the cells of lobular invasive carcinoma. And in some cases, the invasive lobular cells are arranged in a targetoid pattern around ductules. Do you think these ductules are normal or not? What can you identify by morphology and verify by immunohistochemistry? Is this part of the tumor? These are the tumor cells of lobular invasive carcinoma. Why are these normal ductules? What sign is there that makes them benign? What sign is there? What do they retain? They have myoepithelium. Well, they have myoepithelial cells. They have myoepithelial cells. So these are normal ductules that are surrounded by the lobular carcinoma cells. You see how these cells, they do not have much cytoplasm. They are quite homogeneous in appearance, but they are invasive and poorly cohesive cells. Lobular invasive carcinoma. What else is there? Look here. Now, these most probably are residual myoepithelial cell layer. So look at the cells filling this structure, and this is most probable an in situ lesion. Why? Because it retains myoepithelial cells. So how can you tell if this is lobular in situ carcinoma, similar in origin to the adjacent invasive one, or if it is ductal carcinoma in situ, which is again a precursor lesion but with other type of cells? The more common thing to do is to perform E-cadherin. If these cells retain E-cadherin, This is ductal carcinoma in situ. If they lose E. cadherin, they are lobular carcinoma in situ. The homogeneous appearance favors lobular carcinoma in situ because we have lobular invasive carcinoma adjacent, nearby. But I'm not so sure. I'd like to have an immunohistochemical stain performed against E. cadherin, and if there is a complete loss of this adhesion molecule, then I'll be more confident in diagnosing this lesion as lobular carcinoma in situ, poorly cohesive carcinoma.
Because they lose the cadherin. Right?
They lose the cadherin. Yeah, it's not always, but it's very, very often that lobular carcinomatous cells, either in situ or invasive, lose E. cadherin. Okay? It's a very helpful stain, but you should not be based on it exclusively. You should take morphology into account as well. So, what do we see? These are some nerve, peripheral nerves. And what do we see here? The lobular invasive carcinoma extends in which tissue? What are these cells here? Being invaded by the lobular invasive carcinoma? Fat cells, all right? They are invaded because fat cells are a normal constituent of breast parenchyma. Here again we have some sort of, perhaps of in situ. Again, invasion of fat tissue by the lobular carcinoma. And what is this here? That you have to count because lobular invasive carcinomas are also graded. They are graded. Mitosis. So you have to count the mitosis to define this parameter, because there are three parameters, as we said. Solid architecture, where here lobular carcinoma takes 3 points, because there is no tubular architecture in lobular invasive carcinoma. There are solid structures. So it takes 3 from solid architecture. We'll count the mitosis, and the other is the nuclear pleomorphism. These nuclei are definitely not 3, not high grade. Probably 1 or 2, the point for the nuclear pleomorphism. And you should not judge the pleomorphism in high magnification, because all differences are exaggerated when you have high magnification. Choose an intermediate magnification to judge the pleomorphism of the cells, malignant cells. And the last slide we have to examine today is a mixed carcinoma, both ductal invasive and lobular invasive. So, which component might be this one? This one. This here, this one. Which component is this? The ductal invasive component or the lobular invasive component here? That you see this cell? Yes, please? You remember what we saw in the Indian file? You remember that, the Indian file? There was one soldier with the other walking, not all together, like that, the Indian file. So, this may be ductal, this may be lobular. However, if I have a difference in E. cadherin staining, I'll be sure, because this area here will be E. cadherin negative. These cells, negative. So they are lobular invasive. And look that the other, look, please check that the morphology is different. You see, these nuclei are too pleomorphic to be justified, at least the classical lobular carcinoma. They have more pleomorphism. However, there is a not so common subtype of lobular carcinoma, which is called pleomorphic. And this could justify. So you cannot tell by morphology on its own. You have to complement the morphological findings with immunohistochemistry. And in areas where you see absence of E-cadherin, this is consistent with lobular neoplasia. Here of the invasive type, what else is there to see? Here. Look, there is glandular differentiation here. You see the glands? So, which type is that? More probable. Which type is more probable to have this luminal differentiation? The ductal. So here we have the ductal invasive component of the tumor. That's why we call this invasive, breast invasive carcinoma of a mixed type, both ductal and lobular. So let's have a look at other parts of the tumor. Of course, this is scirrhous transformation of the stroma, fibrosis, and this is, it's like a scar, scirrhous appearance. Here we have invasion of fat tissue by the malignant cells. Here we have compact structures compatible with a high-grade component of ductal carcinoma, probably. And here there is some evidence of lobular carcinoma. That's why we call it mixed. This could be an in situ component if myoepithelial cells are preserved. Here are some normal ducts surrounded by some lymphocytes. Anything else here? That's quite a big tumor. Increased diameter, maximum diameter. Look at these cells invading the scirrhous stroma. This scirrhous appearance of the stroma is compatible with breast cancer. So, before we finish our lab, I'm not sure after the new year if we'll have some lessons, I think. We have the gynecological cases of gynecological pathology, and perhaps in another lesson we'll have the slides of the female genital tract pathology. Here, this is the one. Okay? Yes. But we'll do it together because these four systems, urological pathology, male genital system, breast, and female genital system, will have the optional end term practical exam. So I have to cover all the systems. I'll have an extra one on female genital tract so that you know what you can show in the slides. And before giving you my best wishes for Christmas, I'd like to inform you that the evaluation process of what happened in this semester has started. So I think it will be good if you enter the questionnaires in your e-portfolio and just tick the boxes as you like. It's totally anonymous, so you can all do it safely, no way. But I urge you to write what your opinion and what you have, your impressions from the semester. Why? Because as you understood, I do not think that learning medicine is a matter of PowerPoint lectures, then some questions, then exams. PowerPoint lectures, then some questions, then exams. No, this is not my way. However, if you do not want anything else, and you are totally safe with this mode of education, you have to write it so as to know what to do in the next semester. Because if this effort is not acknowledged, there is no purpose of me trying or doing something that nobody acknowledges. It's totally normal. If you say that that's nice, I liked it, I know, and I'll keep on. If you say, what are you doing all this time? And you ask questions and you want us to learn and make practical questions, no, I just want to get a degree. I do not want to learn anything. I want to get the degree, and I'll learn medicine next, when I'll have my residency. It's totally normal. No problem with me, but I have to know. Because if I'm trying to give you something and you do not take it, I'm not that stupid and go on the same procedure. What's the purpose on that? For example, say that you give me a ticket for some game that I'm not interested in. Either if you give me the ticket, if you don't give me the ticket, I won't go. It's none of my, I'm not interested in what you give me. I'm not interested. You have to write it. You have to write it so that I know, and look somebody else, and bring somebody else here. It's not an obsession. What I do in education is not an obsession. I have to know that this is acknowledged, not for my self-confidence, I assure you. No. Not that. I have the psychotherapist and I'm okay with that. However, it has to be acknowledged. Because why? I had during the semester, you remember, somebody called and say, what's going on there in the class? Everybody is noisy. And I said, does this affect me? Because if I'm logical enough, I see that everybody pays attention. So you see that everybody says something that is general, and this generalization is very, very harmful because nobody takes responsibility for something. You have a general remark that nothing is good. Okay, so nobody is responsible. Or everybody is responsible. Because if you diffuse responsibility, it is lost. You do not give it to somebody. You say a general. Nothing is so valid. Okay. So I have to prove that I do something that I consider as important. But if I am the only one considering this as important, I have to know. Because I'm so young and I can change my life. I'm too young. Okay. So, okay, have a nice Christmas and do the evaluation. All right? Yeah. Bye. Yeah. Just the questions. Just a moment, please. Just a moment.